My name is Dr. Jeremy Musher. I'm the Chief Medical Officer and Chief Clinical Officer for Springstone. This webinar is going to focus on guidelines for compliance and documentation and coding, and it applies to all psychiatric medical providers, psychiatrists, psychiatric NPs, and PAs. In psychiatry, we have two coding choices, sets of codes. The E&M codes, evaluation and management codes, that all medical providers can use, as well as what is referred to as the psychiatry family of codes, and these include the codes that we use for add-on psychotherapies, for ECT, TMS, etc. But in addition to the documentation requirements that our billing systems require, the CPT system, we also have other documentation requirements that we need to meet based on CMS and the Joint Commission. And you can see here some of the additional requirements that are related to those regulatory requirements. Our initial psychiatric evaluation, or we sometimes refer to it as the CPE, we need to include patient strengths, and for both the CPE and the progress notes, we need to include, under our mental status exam, how we determined memory, estimate of intelligence, orientation, judgment, and insight. All notes of any kind have to be dated, timed, and signed. And treatment plans need to be individualized using measurable goals and objectives. Discharge summaries have gotten a lot of attention in recent years by regulators, and they are very specific about what needs to be included in discharge summaries. So I would ask that you closely follow the template that I'll be going over and that you have available to you. And then finally, histories and physicals need to have more definition of the neurologic exam. Specifically, they need to include specific information on examining cranial nerves 2 through 12. So let's dive into the E&M codes, and there are two ways to document using E&M codes. One is what's referred to as by the elements, which is the way we document most of the time. The other way is when we use time as the sole determinant of the level of the code. And I'll be explaining to you how we do that. Let's start with documenting by the elements. There are 7 components of an E&M service. 3 of those are considered key components, and those are the 3 here in red: history, examination, and medical decision-making. All E&M visit codes have to include all 3 of these as part of documentation. There are, in addition, 4 contributory components. I'll be talking about how we use counseling and coordination of care as a way of determining the level of the code by time. The other concept that is important to understand is what's called the nature of the presenting problem. This is another way of saying how sick or complicated was the patient visit this time. How much work did you as a medical provider have to do because of a complicated patient? That becomes important because that is what drives the decision about the level of the code from less complex to more highly complex visits are associated with lower codes versus higher codes that we bill for. The exception to that is when we use time as the sole determinant. But whenever we're using the elements, we need to take into account the nature of the presenting problem. So let's look more closely at each of the key components. History and exam are further divided into 4 areas, from problem-focused to comprehensive, and medical decision-making also is further divided to 4 levels, from straightforward to high complexity. Starting with history, history is divided into 4 areas as well. Chief complaint, or reason for the encounter, and when you do an initial psychiatric evaluation for a patient, either inpatient or outpatient, you need to state the chief complaint in the patient's or family's own words, so a quote from the patient. If you're doing a follow-up visit, for instance on an inpatient unit, you can use reason for the encounter. So you might say something like follow-up visit for depression. The history of present illness focuses on primary symptoms, and it must include some number of the elements listed: location, quality, severity, duration, etc. Depending on the level of the bill that you're going to submit, you need anywhere from 1 of these to a maximum of 4 of them. They look like they would fit more appropriately for describing something like pain. Where is it? Is it intense? What's the quality of it? Is it sharp or aching? How long does it last? When does it come on? Is it associated with anything? Does anything make it better or worse? Etc. You can do the same thing with a psychiatric symptom. So you could take something like depression and talk about, is this the worst depression you've had? How would you rate it? 1 to 5. When does it come on? Does anything make it better or worse? Is it associated with anything else that's happening? So you can use the same way of approaching it in order to get 1 to 4 of these elements. The next part is a medical system review. There are 14 systems listed here, and CMS and other payers consider a complete system review to be any 10 of these systems. And we'll talk in a minute about how you can document that. And then the 4th part of a history is the past family and social history. Past history here includes both past medical history and past psychiatric and addiction histories. Family history means asking the question, does anyone else in your family, do you have any blood relatives who also suffer from psychiatric or substance use conditions? And then social history. Now, when you have to document a system review, you typically, for follow-up visits, only have to document either the pertinent system, which is psychiatry, or the pertinent system and 1 other. So you, for instance, could use a potential side effect of a medication you're using and ask a question related to that, like GI side effects. For a complete system review, you need to have at least 10 of those systems that were on the previous screen addressed, and you can document it by only documenting the pertinent positives and negatives and then using the phrase all other systems negative. Now, you're going to need a complete system review for any new patient evaluation in order to meet the billing requirements for a new patient evaluation at the levels that you will typically be billing. One way to meet this requirement is similar to what most of us have experienced when we walk into a primary care doctor's office or any other medical specialist's office. And typically what happens is someone at the front desk gives us a form to fill out that is essentially a system review. So we have a review of systems form that is to be completed by the patient. It contains at least 10 of the systems, and there's room at the bottom for both the person who completes the form to sign it, date it, and time it, as well as for the provider who reviews this, which is the psychiatrist or psychiatric NP or PA, to write any comments based on what the patient has checked, and then again sign it, date, and time. Then on the templates that we use for the initial evaluation, you could just check the box that says refer to the system review and make sure this is part of the record. This is a template that we use for comprehensive psychiatric evaluations for inpatient. And I just wanted to call your attention to the chief complaint needs to be in the patient or family's own words as a quote. The HPI then has the elements listed, and the system review, you have the opportunity to check a box that says see ROS questionnaire, or a box if you were to document significant positives and negatives, you could check the box that says all other systems negative if that was true. I also wanted to call your attention to how the templates are all, how all the templates look. They all have these banners in black for each of the three sections, the history, exam, and medical decision making. And if you look at them, you'll see that you can tell exactly what the requirements are based on the level of the code that you've decided to bill. So for instance, if you're billing a 99222 or a 99223, the middle or highest level inpatient evaluation codes, it says you need 4 HPI, so that means 4 of the severity, duration, quality, timing, etc. elements, all ROS, so you need a complete system review, and at least one element from each past history, family history, social history. Now, there are really a limited number of codes for you to be familiar with. For inpatient, we have the 3 that I mentioned, the 221 through 223, as the initial inpatient psychiatric evaluation. For progress notes or follow-ups, for both inpatient and partial, for most of the country, there are some exceptions, and I'll note those as we go through. There are also only 3 codes, 99231, 32, and 33. Discharge day has 2 codes, and I'll describe to you the difference between these two, 38 and 39. For our outpatient CPEs, we actually only use 1 code, 90792. We don't use the E&M new patient codes for outpatient, and there are a few reasons for that. The main 2 reasons are that there are some complicated rules about whether you or another member of the same group has seen the patient before within the last 3 years. And if they have, or you have, then you can't bill a new E&M code, even if the patient's coming back for a whole new service, and you haven't seen them a couple of years. And the other reason is that the value RVUs for a 90792 are actually pretty good since 2014. And so from a financial standpoint, it's pretty much a wash whether you bill a 90792 or the typical codes that would be billed as E&M new patient. Then outpatient progress notes, there are 5 levels from 99211 through 215. You see that there are only 4 listed here, and that's because the 99211 is actually a code that does not require the presence of a psychiatrist, nurse practitioner, or PA. The presence of a nurse can qualify for billing a 99211 level. This is a history cheat sheet. It shows you in one slide the 4 levels, what's required for each level, and the corresponding codes that apply to that level. So, for instance, if you are billing a 99232 or an outpatient 99213, then that's an expanded problem-focused service or expanded problem-focused requirement. So you need a chief complaint, which every service needs. One element from the HPI is all you need at that level, and the pertinent system. So when we talk about the pertinent system, the way you would document that is, let's say, for example, that you have a patient who you're treating primarily for depression symptoms. You would ask the patient questions related to other aspects of psychiatric symptoms, like anxiety, perhaps psychosis, if that had been part of their depression in the past. And those would be part of your system review of the pertinent system, because they're not the actual primary symptom that you're addressing in the HPI. Now let's move to the second of the key components, which is the psychiatric specialty exam. The specialty exam actually contains 3 parts, the first of which is the mental status exam. And I just want to call your attention to a few things that may be a little different from what you were trained to do going through residency. First of all, the requirement in an inpatient setting or a partial setting by the Joint Commission is that you have to show your work and describe how you determined the orientation, recent and remote memory, fund of knowledge or estimate of intelligence, and judgment and insight. The other areas that might be a little different are that this exam includes language, which is the neurologic sense of language, naming objects and repeating phrases. Another part is that thought process is a separate bullet from associations. I was taught, and I think many of you were probably taught, that associations is part of thought process. But under this exam, it's a separate bullet. And then finally, if you look at thought content, you'll see that it contains essentially the meat of the psychiatric evaluation. Delusions, hallucinations, suicidal, homicidal. But it only counts as one bullet. And the reason that I'm referring to these bullets that are off to the side there is that in determining the level of the code, you are going to need to document some number of these bullets to meet the documentation requirements for that level. And there are typically you're looking at either, for very low level codes, one of these, then 6, 9, or for the highest level of some of the codes, you're going to need all. And again, those banners on the documentation templates and the dictation template that I'll show you all contains exactly what you would need for the code selected. Now the second and third parts of the specialty exam include the constitutional exam, which is 2 bullets, 3 of the 7 vital signs, any 3, and general appearance, which we normally think of as part of a mental status exam anyway. And then musculoskeletal, where you need to document either gait and station or muscle strength and tone. So for a comprehensive exam at the highest level of some codes, you need all the bullets, which means vital signs and either gait and station or muscle strength and tone, in addition to all of the mental status, including general appearance. This is to show you what the template looks like that you would be documenting from, and this is the a part of the mental status exam on the template. And again, I wanted to call your attention to the requirements in the banner. It says that a 99222 requires a minimum of 6 of the bullets. In this situation, bullets are these boxes of the different elements, and you can see some of the boxes contain 2 parts. So for instance, appearance and behavior says complete both. That all counts as 1 bullet. Mood and affect, complete both. That all counts as 1 bullet. Calling your attention to the highlighted sections, orientation, memory, estimate of intelligence, and judgment and insight. And you can see in some of these I've included methods, so it is a way for you to identify how you determine them. So for memory, for instance, if you check recent and remote are both intact, you can check that you used you can use ability to relate recent and remote history and remote personal history as the 2 ways that you determine that. For estimate of intelligence, if it's, for instance, normal, you can check that that was based on the patient's vocabulary use. Or if you did actual formal testing, then you can check that. So that's how this is set up on the actual template that you'll be filling out. Now, most of you dictate the CPE, initial psychiatric evaluation, and the discharge summary. Some also dictate some other documents, but most of you dictate those 2. There is a dictation template, this is just a picture of it, that is a trifold document. Both sides have writing on it. And it contains the templated dictation that is on the actual forms that you could handwrite, but this is all the information you could use to dictate from. And it includes all the same triggers for remembering, for instance, to show how you determine memory for the comprehensive psychiatric evaluation. On the back in the middle here, you can also see, if you look closely, that it says example of normal exam. There's just a dictation of a normal exam. Now obviously we would expect most of our patients don't have a normal exam, but the sections that would be abnormal, obviously you would change to whatever was abnormal. It's just there for your information. Also some information about dictation, what information has to be included, etc. This is the cheat sheet for the exam portion, the psychiatric exam. And you can see that for a detailed exam, which would be for a 99233, the highest inpatient follow-up visit, or a 99214, which is an outpatient higher level but not the highest level outpatient visit. You need 9 exam items related to a bullet. So it's easy to remember. You always need either 1, 6, 9, or all. Now, the third key component is medical decision making. And this is arguably the most complicated of the three. So let's go through this in some detail so you understand it. There are 4 levels. You can look at the left column. Straightforward through high complexity medical decision making. And then if you look across the top, you'll see 3 additional columns. You need 2 out of 3 of those columns to meet or exceed the requirements in order to bill at that level. So let me explain. The 3 parts of medical decision making are the number of diagnoses or treatment options, or another way to think of it is management options, the amount and or complexity of data to be reviewed, and the third is the risk of complications, of morbidity, mortality. So it's number of management options, amount and or complexity of data, and risk. Well, for psychiatry, the way the system works in terms of what you get credit for, and I'll show you that in a minute, psychiatry rarely gets enough credit for complexity of data to be reviewed or amount of data. So I'm going to show you a simplified way of addressing all this rather than this. The other thing that I want to call your attention to is that this does not appear very quantitative. Limited, multiple, moderate, these are not quantitative terms. They're somewhat subjective. This is the table, however, that is in the CPT manual. So when this table came out, the individuals who are the coders who actually come and audit you looked at it and said, we can't work with this. It's too subjective. So they came up with this. This is a much more complicated way of giving point credit for different parts of those 3 areas. You can see the middle is the risk table and talks about examples of different levels of risk. The top part talks about the number of diagnoses or treatment options and gives you numbers of points for whether it's an established problem or a new problem, whether you've done additional workups or you're planning to, etc. And the amount and or complexity of data, and the reason that we don't get a lot of credit for it in psychiatry is that it includes things like ordering clinical lab tests, ordering tests, radiologic tests, discussed it with the performing physician, and some other things. Typically, you don't get enough points to make that a helpful part of the 2 out of 3. So how can we simplify this? Because this is not user-friendly, to put it mildly. Well, the 2 categories that are always present in every encounter are the number of management options or diagnoses, and I prefer focusing on management options because you could have a very complicated patient with only 1 diagnosis. Or you could have a patient who's really quite stable, but with 3 stable diagnoses. So the issue really is more about management options. And the second category that's in every encounter is the level of risk. And that's based on the risk table. And there are some parts of the risk table that apply very nicely to psychiatry, and I'll be going over those. So this is how we have the psychiatric CPE, the initial evaluation, set up for the medical decision-making portion of the note. You can see that the assessment of presentation is a narrative section for you to include, and in this section you're going to sort of summarize your assessment of what's going on with the patient, and in that assessment you need to say something about risk. So you need to talk specifically about any lethality issues, suicide, homicide, as well as your rationale for this patient meeting inpatient level criteria. So that gets you at the risk. Then for the management options, I've set it up so that you can easily see, based on the code you've decided to bill, and again, your decision about the code level is entirely based on the complexity of the patient's visit and how hard you're working from trying to figure out what's going on and what you're going to do about it, which is the nature of the presenting problem. So you first determine the nature of the presenting problem, in other words, the complexity of the visit, and you know that pretty quickly as you're talking with the patient. And then based on that, you decide the level of the bill you're going to be submitting. And then once you know the level, then you start documenting to meet the requirements for that level. So let's say you've decided that this new patient, the level of complexity is not the highest level that you see, but the next level down, a 99222. And I'll show you data in a little bit on how other psychiatrists across the country bill, what levels they bill by percentage, by psychiatrists, so you can see where you fit. So a 99222 has the number 3 next to it for under management options. What that means is for a 99222 you need to come up with at least 3 management options that you're going to address with the patient. So one might be related, for instance, to a particular medication that you're going to start. A second might be related to family therapy and what you want the social worker to be focusing on with the patient and why they need family therapy. A third might be related to your ideas about what you want the patient to get out of the CBT group. Or it might be about a second medication that you're going to either add or adjust the dose on. So it doesn't, the management options are not limited to medication. You're the attending or you're the primary medical provider responsible for the patient, and so you're addressing all of these. It doesn't necessarily mean you have to provide the group therapy to write it down here. And then after the management options, you have a space there for the patient's strengths. You need to document for inpatient and partial the patient's strengths, and you need to say something about strengths related to what attributes they have that will help them to be able to be treated as part of their treatment plan, what will help in their developing a treatment plan for them, and then estimate of their length of stay. So let me describe in a little more detail the two areas and how you would determine and document the two areas, the number of management options and the level of risk for the different levels. Looking at level of medical decision making from high at the top to straightforward at the bottom, you can see that you need at least 4 management options at the highest level, only 1 at the straightforward level. The level of risk from high to low, I've given you examples based on the risk table for psychiatry, and let me call your attention to moderate. For moderate risk, according to the risk table, anytime you prescribe a medication, so it's not over the counter, it's prescribed medications, which I would venture that 98-99% of inpatients are on prescribed medications, that automatically puts them at a moderate level of risk. High risk involves patients who are either having or you're addressing suicidal or homicidal ideation, intention, plans with, or it could be that they're on a medication that requires intensive monitoring. This would be something like Clozaril. It could potentially be lithium or Depakote, for instance, but only if you're just getting started with them would you be intensely monitoring them. If they've been on it for quite a while, it's not really requiring intensive monitoring. So that gives you an idea of what you need for the different levels of medical decision making. So if you don't have the template right in front of you, what's an easy way to remember this? Well, if you're dealing with a code set that has 3 levels, and right off the top of your head you can probably think of inpatient, that has 3 levels for both the initial evaluation and 3 levels for progress notes. So in code sets like inpatient, where there are 3 levels, if you need a high level of medical decision making, because you're billing level 3, then you need 4 management options. If you're billing at a level 2, you need 3. So for code sets that have 3 in them, 3 levels, you go up 1 number from the level of the code to determine the number of management options you need. Once you've prescribed medication, you know you're already at moderate risk. So to get to high risk for those patients, and remember, both the management options and the level of risk need to be at or above the level that you're billing at. So, for instance, if you've decided that you're billing at the highest level, a level 3 inpatient initial evaluation, you would need to have at least 4 management options and high level risk. If you're billing at a level 2, you would need at least 3 management options and at least moderate level risk. But you might have, for instance, only 3 management options and high level risk. You'd still only be able to bill at a 99222. Now, let's say you had a code set that had 5 in it, and that would be outpatient. Outpatient code sets, remember, had 99211 through 215, even though we don't use the 211 to bill, it has 5 in it. So for the highest code in outpatient, a level 5, you need 4 management options. So for code sets that have 5 in them, you go down 1. If you want to bill a level 5, you need 4 management options. A level 4, you need 3. And then the level of risk you can see. And again, you need both to be at or above that level to bill at that level. This is an example of what you need to bill at the different CPT code levels. This is for an inpatient. And one of the rules is that for your initial codes, like the initial inpatient day codes, you need all three of the key components to be met or exceeded in order to bill at that level. So what would that look like? Well, as an example, if you had a comprehensive history and high complexity medical decision making, but only a detailed exam, and if you go back, you can see that a detailed exam would be because you need for comprehensive exam every single bullet, if you missed one bullet on the exam, let's say you forgot to say something about associations or about language, that would knock you back to a detailed level, which would mean that instead of being able to bill a 99223, you'd only be able to bill a 99221. You went from the highest to the lowest. That is the reason to impress upon you that you need to do a comprehensive exam on these initial patient visits, because both the 99222 and the 99223, as you can see here, require a comprehensive level exam, which is one from every single bullet. Now, for a subsequent visit, you only need 2 out of the 3 key components to be met or exceeded. And one of those should be medical decision making. The other could be either history or exam. And this example shows you that the history was high enough, was detailed, and medical decision making was high complexity. But even though the exam was not detailed, you could still bill at the highest level because you only need 2 out of 3. So let's talk a little bit more specifically about inpatient, and let me give you some of the statistics that I mentioned before. So this is information. It's Medicare only because commercial data is proprietary. So based on Medicare claims from 2016, psychiatrists billed with this distribution the initial hospital day codes. Almost a split between 222 and 223, and about 14% billed a 221. So about 85–86% of patients were at a 2 or 3 level. Now, why do I show you this? Because one of the reasons that you may get audited is because your distribution is significantly outside of the norm. And that's why I want to show you what the norm is for your peers across the country. This just gives you a reminder of what the requirements are for the initial hospital visit. And as you can see, again, most are going to be billed at a 222 and 223. And the only difference between those is the level of complexity of medical decision making, whether you have high complexity or moderate, because both require comprehensive histories and exams. So what about follow-up visits? Well, again, based on 2016 data, you can see what the follow-up visits are. About half of your visits, or a little more, are at the middle level, 99232. About 28% are 3.1, and only about 14 or 15% are at the highest level, 3.3. Typically, the patients who are at 3.1 are relatively stable. They're getting ready for discharge. 3.3 patients are patients who are unstable, or they've developed a new problem that you have to work up and be concerned with, and they are at high risk, suicidal, homicidal, etc. All the other patients are in between, and they're the 3.2s. Now, I do want to call your attention that in Ohio and Indiana, they prefer that partial codes, this is partial only, you use the outpatient codes. Inpatient, you still use these codes. So this just gives you, again, what is required for each of these levels. So what about the discharge day? Well, on inpatient, on your day of discharge, you have two codes that you can bill, 3.8 and 3.9. And it's about 2/3, 1/3 in terms of how many are billed 3.8 versus 3.9. The difference between the two is time only. The discharge day code is a time-based code. Doesn't have to do with complexity. It only has to do with how much time on the day of discharge. Has to be on the day of discharge. Can't be the day before, the day after. On the day of discharge, how much time did you spend related to the care of that patient? And now it can include meeting with the patient, meeting with family, calling an outside provider that you're referring the patient to and talking to them. Can be your documentation time, can be your dictation time, can be your time writing scripts. All of that time counts so long as you do it on the day of discharge and you do it in the hospital, on the unit. This is just to give you an idea of the specificity required on the discharge summary, and this is on the dictation template, as well as there is a form that could be handwritten that includes all of this. So we ask that you very closely follow this in order to meet all of the detailed requirements on it. This is the handwritten version of it. We need to include psychiatric, medical, and functional condition on discharge. And by functional, they are looking for something like, can they do their ADLs and self-care? Now let's talk about outpatient, established patient visits, follow-up visits, and how we would document for an outpatient visit. Now keep in mind that in outpatient and inpatient follow-ups, you only need 2 out of the 3 key components to be met or exceeded, and at least one of those does need to be medical decision making. So we can see that in this example, you meet requirements for a 99214 level because you have 2 out of the 3 at or above the level needed. So medical decision making is met at the level, and comprehensive history is above the level, so you have 2 out of the 3 at or above the level, even though the exam is below the level needed. This just gives you what the requirements are for each of the 4 levels that we use in outpatient. And this helps you to compare yourself with your peers across the country in terms of 2016 data for how they build these services. And you can see that over half are at the 213 level, about 1/3 at the 214 level, about 6 or 7% at 212, and only about 3.5% are at the highest level outpatient, 215. In order to meet complexity requirements for the highest level in outpatient, you really need a patient who you're assessing for suicidality, homicidality, severe psychosis, where you're considering inpatient and doing a more comprehensive evaluation of the patient to determine that. Probably even a number of these patients who were billed at 215 were billed there based on time for counseling and coordination of care rather than complexity. And let me show you how we can use time based on counseling and coordination of care to determine the level of the bill. So when greater than half the time for inpatient, it has to be on the floor unit, and in outpatient, it has to be face-to-face. If greater than half the time of the visit is spent in providing counseling and coordination of care, then you can use time as the sole determinant of the level of the code. But counseling and coordination of care means something very specific. Counseling is not therapy. In this context, counseling is basically education. When you are educating the patient and or family about things like prognosis, management, medications, it's all about education as counseling. Coordination of care is when you coordinate care with another healthcare provider. And again, keep in mind that if you pick up the phone in your office and call another healthcare provider and the patient's not there, that time doesn't count. In an outpatient setting, you have to be face-to-face with the patient in order for any of this time to count. So how do you document that? You put the total time of the visit, and then you put time spent counseling and coordination of care, as long as it's 50% of the total time and it meets the requirement of being truly counseling or coordinating care, and you meet the threshold time of that bill, of that service, then you can bill based on that. So what do I mean by threshold time? Well, you can find the threshold times in the CPT manual for every code. They're, in the CPT manual, they refer to them as the typical time spent on that service. But you'll find that in all the templates that we have that you're using, at the bottom, there is a section for time-based billing, and it tells you for those codes, so in this example for code 99232, follow-up inpatient or partial visit, you need to have spent a total time of greater than or equal to 25 minutes. So if you're going to bill that visit as counseling and coordination of care, then at least 13 of those 25 minutes would have had to have been spent in counseling and or coordinating care. And if you did that, you could put in the blank the total time, let's say it was 25 minutes, the time spent in counseling and coordination of care, and it's an estimate of 14 minutes. Then you describe below that what you actually did for the counseling and or coordinating care, so that it's clear that what it was that you did. So all of the templates have a space for you to be able to do that. Now let's talk about the psychiatry family of codes. The codes that we most commonly use in this family are the psychotherapy codes. I'm not going to get into the ECT, TMS codes because they're very specific, and I'm happy to talk with anybody who's providing those services about how to meet those billing requirements. How to use psychotherapy add-on codes? Well, first of all, psychotherapy is a procedure. It's a service. Every time a psychiatrist talks to a patient, that's not psychotherapy. Psychotherapy means a specific modality of an established treatment that was thoughtfully provided to a patient for a specific reason. So it's like choosing a procedure. The service itself must be significant, and in order to be significant, it has to have met certain time thresholds as well as be a real procedure, be a real psychotherapy service, and must be separately identifiable. That just means that there has to be a separate part of the note that specifically addresses that you provided psychotherapy and what you did. And I'll show you how we do that. And then you select the appropriate E&M service by type and level. It must be based on the elements. You can't, if you're doing an add-on psychotherapy service, you can't base the E&M portion of the service on time for counseling and coordination of care. It has to be based on the elements. Then, without using any time devoted to the E&M portion, you determine the psychotherapy time and code the appropriate add-on code. So what that means is we all know that when we do psychotherapy as well as E&M in a given session, you're not starting and stopping a clock for, oh, right then I was doing E&M, oh, right then I switched to psychotherapy. It's an integrated service. So in your head, you need to think, okay, I just spent 30 minutes with this patient. Of that 30 minutes, how much of the time approximately was E&M? And then when you subtract that out of the total, how much time was left? And of that was left, was it all psychotherapy? And based on that time, we can bill the psychotherapy. So let me take us back to the bottom of the note, and you can see right below the time-based billing, there's a section for additional psychotherapy. Was additional psychotherapy provided, yes or no? If yes, we need to indicate the time. So below it is psychotherapy face-to-face time. For the minimum requirement for time for psychotherapy is 16 minutes. So if you've spent more than 16 minutes of actually doing psychotherapy with an add-on, or with a E&M service, then you can bill this 90833 code. If the time minimally is 38 minutes, you can bill the 36, and if the time is at least 53 minutes of psychotherapy in addition to the E&M time, then you can bill 90838. So you choose one of those, then you put the actual time. So if it was 20 minutes, then you'd bill the 90833, but you'd put psychotherapy time 20 minutes. Then you put the modality of the psychotherapy provided, as well as the focus and of the psychotherapy, what were you actually doing in the psychotherapy, and what progress did the patient make towards treatment goals, specifically psychotherapy treatment goals there. Okay? So, we've covered the E&M codes that we use and how to document them by the elements as well as based on time. And we've covered some of the most commonly used psychotherapy codes, the concept of how you would bill them, and what documentation requirements you would need. So thank you for joining me, and I wish you the very best. And if you have any questions, please feel free to contact me. Thanks. Have a great day.